registered, so I think more people will be trickling in, which is wonderful. It's the beauty of a virtual session. I'm excited that we have Dr. Dennis Kerrigan here to speak today, and I'll introduce him in just a minute. For those of you that don't know, I am Kelly Martins. I am a clinical health psychologist in bariatric surgery at Henry Ford Health System and the chair of the Integrated Health Committee. Also here with Dr. Hammond.
Just a reminder, Aaron Hammond, Senior Staff Psychologist, Henry Ford Health System. Welcome, everybody.
And co-chair. All right, just a couple of nuts and bolts things before we get the meeting started. This will run just the same as the larger MBSC meetings. So what that means is throughout the duration of the talk, participants' videos will be off and you will be muted. If you have questions at any point in time, though, please feel free to type them into the Q&A at the bottom of your screen. And then toward the end, Dr. Kerrigan will save time for questions, at which point Rachel and Amanda will kind of filter through the questions and introduce the participant so that they can, ask their question for Dr. Kerrigan and he can address those. All right, before I introduce Dr. Kerrigan, I wanted to do just a quick poll to see what everyone prefers in terms of future integrated health meetings. So historically, we have held the integrated health sessions when we were doing in-person meetings right before the larger triannual meeting. But now that we're doing some virtual meetings, we wanted to kind of see what works best for people and what your preferences are. So we can put the poll question up. The question is, moving forward, when would you prefer to meet for the MBSC integrated health sessions? Either in the morning on the day of the main MBSC triannual meeting, so that would be February, June, and October, or on a day separate from that. So in between, for example, like we're doing now in April, August, and December. So go ahead and take a second and submit your preference. Okay. So almost 2/3 of people would prefer that it's held on the same day of the MBSC meetings, more convenient perhaps. Okay, great. That's helpful. Thanks, everybody. Can I close that? Okay. All right. For some reason, my slide is not advancing. There we go. All right. So now I wanted to introduce our guest speaker today, Dr. Dennis Kerrigan. Dr. Kerrigan is a registered clinical exercise physiologist. He is the director of outpatient exercise programs and the Livonia and Detroit locations of Henry Ford's weight management program. He earned his BS from Bowling Green State University, his MS from Eastern Michigan University, and his PhD from The Ohio State University. In his current role as the Director of Outpatient Exercise Programs and Preventative Cardiology, he oversees the downtown Henry Ford Hospital Cardiac Rehabilitation Program, as well as exercise programs for cancer and bariatric populations. In addition to his clinical duties, Dr. Kerrigan also conducts research in patients with heart disease, cancer, and obesity. He was the primary investigator for the REHAB-VAD trial, the first randomized trial of cardiac rehabilitation in patients in the United States with left ventricular assist devices. Currently, he is a site PI in a study along with the University of Michigan examining the effects of bariatric surgery and high intensity interval training on distal symmetric polyneuropathy. Hopefully I got that right, it's a mouthful. He is also a past president of the Clinical Exercise Physiology Association. Very excited to have Dr. Kerrigan with us today. I know his talks are very interesting, and I was just saying that I learn something every time I hear him speak. So we'll turn it over to him. Dr. Kerrigan.
Okay, well, thank you so much, Kelly, for that introduction. And I'd like to thank Kelly and Aaron and the Integrative Health Committee for having me here today. I'm very excited to be here. And really what I hope to share with everybody is just to pass along maybe some gems and tips for helping you work with patients in terms of counseling them with exercise and what are best practices and guidelines. So really that's my goal, is to give you the most up-to-date information to help your patients. So as far as the overview today, I plan to go over how exercise is an adjunct to bariatric surgery, what it gives patients in addition to the great benefits from bariatric surgery, what are the current guidelines for our patients, what are some special considerations you need to be aware of so your patients don't end up like this guy right here on my slide here. And then finally, I'm going to finish up with what are some considerations in terms of maybe seeing the patient before surgery and assessing their functional capacity, and how that could be helpful in both kind of risk assessment as well as making sure they're on the trajectory for success. So I could probably spend all day talking about all the great benefits that you get from exercise. And I don't know who first coined this phrase, you know, if you can bottle up the benefits of exercise, it'd be the most widely prescribed medicine in the world. But I don't think I've ever had a talk where I don't talk about this, because when you talk about, you know, all the great benefits you get from exercise, you know, it's really comprehensive, if you will. So in terms of various organs in the body, the pleiotropic effects that we're learning, you know, it seems like every week there's a new study that talks about the benefits of exercise. More recently, interestingly, we're seeing some information coming out, and I may share with you guys today some research we did in terms of how exercise can help boost your immune system and protect you in terms of COVID, as well as some mental health benefits in terms of symptoms of anxiety, depression, dementia, and cognitive decline. So many good reasons to exercise, to say the least. With respect to bariatric surgery, exercise can give some added benefit. Now, one thing I stress with our patients is you're going to lose all the weight you're going to need to lose with bariatric surgery. There's really not a whole lot of evidence that you're, especially during the rapid weight loss phase, that exercise is going to enhance that weight loss that much more. In fact, I often tell my patients you could do nothing and still lose a lot of weight with bariatric surgery, but I'll get to some of the downsides to that later. But we do know that there is, you know, a small percentage of patients, around 20%, that are refractory to bariatric surgery. Meaning, you know, for whatever reason, they don't lose the weight we would expect, or they regain the weight. And so, you know, for all patients, exercise is important, but especially in this population. We also know that while we do see some remission in terms of some metabolic disorders like diabetes number 1, exercise is crucial because it helps in other mechanisms different from what we see just with weight loss. So to illustrate that, I have a little animation that I put together for a class I taught a few years ago. And this really describes, you know, why the muscle is so important in terms of blood glucose control. So really, when you think about the you know, blood glucose control, obviously the liver and pancreas come to mind, but really the muscle is the largest reservoir we have for glucose in our body. And so that's why muscle is so important. But just to refresh your memory from physiology, you know, the pancreas releases the insulin. We have this cascade of events that lead to translocation of the GLUT4 receptor that moves to the surface of the muscle, which pulls in glucose. And that's how our bodies were designed. However, with 21st century lifestyles that we see, and just in case you can't see on the screen, this mouse has some chips and empty bottle of pop there. But what happens is this process gets gummed up. And so it actually takes the pancreas more work to release more insulin because the muscles are not as receptive. And one of the theories behind that is the fact that you have this metabolic disorder where you have these circulating triglycerides, especially through visceral fat in the stomach, that the muscle takes in because the muscle can use fat for energy too, but because the person's not exercising, mitochondrial levels are really low, and the muscles start to accumulate these toxic fats. And because of this accumulation of toxic fats, this is actually the mechanism that is proposed to why the muscle becomes desensitized to insulin. Now, to reverse that, obviously, exercise is essential, and one of the reasons why it is so essential is because it works through a different pathway, the AMPK pathway, to translocate the GLUT4 vesicles, so you can actually bypass, the insulin pathways here to bring glucose into the cells. And so short term, that has great benefits, and I always point out to my patients when I take their blood sugar before and after exercise, I show them, wow, look what one bout of exercise can do for you. But long term, what that translates into is increased density of mitochondria, making the cell more efficient in terms of helping control blood glucose. And so we see this in terms of increased hepatic insulin sensitivity, greater beta cell function, so a lot of pleiotropic effects with exercise. So that brings me to a very important question that I always ask my patients is simply, how much exercise do you need? And so obviously we probably all have heard somewhere along the lines that you need 30 minutes of exercise 5 days a week. And I tell my patients that's great, that's well and good in terms of the overall healthy adult guidelines. But when we talk about weight loss and weight maintenance especially, we're really talking about more than that. So somewhere in the neighborhood of 200 to 250 minutes a week. So actually, speaking of that, that brings me to my first question for the audience here is, so we did a survey a few years ago where we looked at how much exercise Henry Ford bariatric patients are doing after surgery from years 1 to 5. And so I wanted to ask you guys, hopefully you guys are awake enough now, how much exercise would you expect Henry Ford patients to do after surgery? And so we're going to bring up the question here. And so Amanda, if you have a chance to bring up that question. And while she's doing that, I'm going to go through your answers so you can think about it. So answer A would be, exercise after surgery gradually increases in individuals. It gradually decreases. It precipitously drops after the first year. It increases precipitously after the first year, or it remains unchanged from before surgery. So we'll give you guys a few minutes and go ahead and give me your answer. Okay. So it looks like 63% of you says it drops precipitously after the first year. So some of you must have got my slides ahead of time. So, but you guys are absolutely right. Looking at the data here, after the first year, we see a dramatic drop in exercise, and actually another drop after year 2. And while this was self-reported data and a retrospective study, it's interesting to kind of speculate on why the changes are what they are. And I actually think that it's probably related to what happens in terms of your the weight loss trajectory. And as many of you know, looking at the graph, just to orient you here, at the bottom here, the x-axis is % weight loss. And you can see patients here in my cohort peaked around year 2, and this is expected because this is mostly the Roux-en-Y patients. But I feel like that probably the relationship between exercise and weight loss with bariatric surgery is that first year patients are really excited. They're probably doing a lot of exercise. They're seeing all this weight loss, and that weight loss slows down, and that probably hampers motivation because, as a lot of you guys are aware of, when it comes to exercise, the #1 reason patients do it is to lose weight. But what we wanted to do in this study was we wanted to look at those patients that maintain their exercise at least at 3 years. And so first of all, we took a cutoff of 200 minutes a week of exercise, and we basically looked at it as a dichotomous variable. So patients who were below that level, what were they doing? And as many of you might expect, their weight regain was greater than those people on average. So not exercising or doing less than 200 minutes looked like it was suggestive of greater weight gain after surgery. And then we looked at people who are doing over 200 minutes a week, and we found that their weight was actually stable at year 3, maybe indicating that these patients, again, that the exercise can help protect that weight loss. And that's really my big message for patients who are coming in for bariatric surgery. I tell them, the exercise is not going to help you lose a lot of extra weight, but what it will do is going to help protect that weight. I imagine that probably a lot of you have watched at least one season of The Biggest Loser. It's been on for nearly 20 years now. And while there are some good things about that show that I've enjoyed it myself in watching the amazing transformations and the stories, I think it's done a real disservice to my profession, for one thing, and really just perceptions that both patients and even clinicians have in terms of what exercise can or what exercise cannot do. And so, when I talk to patients, whether it's for bariatric surgery or the weight loss program, and they kind of hit kind of a plateau with weight loss, the first response patients have is, oh, I need to get to the gym more, I need to exercise more. And that's always great. I always encourage that. But I think as far as, how much exercise a patient needs to lose weight, there's a misunderstanding, to say the least. So with that, I'm going to bring up another poll question for you guys, and you guys aced the last poll question. And this next poll question is asking you guys, the same question I asked my patients, is if we were trying to lose 1 pound of fat and we went out for a walk today, how many miles of walking does it take the average bariatric patient to lose a single pound of fat? So again, I'm going to ask Amanda to go ahead and bring up a poll question. Thank you, Amanda. Give you guys a few minutes to answer. Okay, so the results are, wow, they're really mixed here. They're kind of all over the place. But by a slight majority, it looks like you guys got the right answer again. So it's somewhere around 20 to 30 miles. A lot of times patients will tell me, it really depends on how fast you're walking. And the answer is no, it doesn't. You get done sooner, whether you get to 22 miles or 27 miles to lose a pound of fat. But how fast you walk, doesn't really matter in terms of burning calories during that time frame or the distance. So anyway, but as much as The Biggest Loser has caused me headaches trying to re-explain exercise for patients, I think it's a great example of what happens after you lose the weight. And so there's a number of studies that have looked at these contestants, and this was one that was done in 2017. So this was done in 14 contestants. Half of the contestants were able to at least have a 24% weight loss still at 6 years, whereas half of them gained back most of the weight, if not all of it, and then some. And so, so the purpose of this study was really to look at what's the difference between patients who you're able to maintain their weight loss and patients who gain their weight back. And this next slide, I think, is really fascinating and really drives home a point that I always talk to my patients. Again, when it comes to weight loss, I like to tell my patients, you cannot outrun your fork. And so if you look on the left-hand side, it talks about 6 weeks of weight loss during the competition. And so at this time, patients were exercising a lot, as we know for anyone who's seen that show, but we can't forget they're also watching their diet. And so the graph here that you're looking at, you see that when you compare the energy intake, okay, versus the change in physical activity, the more reduction in energy intake, the greater the weight loss. And so there is a very strong correlation in terms of the diet here and weight loss. For exercise during that 6 weeks, there's no correlation, okay? And again, I emphasize this to my patients all the time, that first year after surgery, it doesn't matter how much exercise you're doing, you're gonna lose a lot of weight. And so I warn them not to be fooled by that first year, because during that first year, patient could skip the gym for a week or two, still lose a lot of weight, and start to think to themselves, oh, maybe I don't need this exercise. And so that's a caution that I often give the patients. On the other side, if you look at the right-hand side here, the correlation is much weaker in terms of exercise, okay? And then much weaker in terms of nutrition, although it's still related, but exercise seems to have a much stronger role now, 6 years after the initial weight loss. And so again, this really adds to the vast literature that talks about how exercise is most important in terms of maintaining your weight loss. And that's really the emphasis that I again have with my patients. So just to kind of help solidify that, if we take a 300-pound patient, okay, and they're walking at 3 miles an hour, that's roughly going to be 11 laps for them to burn 450 calories. Somebody who loses weight after bariatric surgery, say they lose 100 pounds, for that same 3 miles an hour, for them to burn 450 calories, now what they need is at least 14 laps. So this could be the difference between taking 55 minutes to exercise versus 70 minutes to exercise for an average patient. And this is another kind of fallacy that a lot of patients have when it comes to weight loss and exercise. They think, oh, I'm losing the weight, I don't need to exercise as much. Actually, it's the opposite. The more weight you lose, the more exercise you need to do, because you're burning less calories because you're carrying less body weight. So especially in terms of non-weight bearing exercises. But that does bring to a question that a lot of patients have that I'm very careful at answering. And that is, well, what about the exercise intensity? Can I just save time by working harder? And the answer is, of course you can. So if you look at a moderate intensity exercise of walking at 3 miles an hour on the treadmill versus jogging at 5 miles an hour at the treadmill, for 250 minutes versus 95 minutes, the amount of calories you burn is relatively the same, okay? So you save a lot of time if you're able to jog. But of course, the challenge is with most of our patients, very few patients can jog at 5 miles an hour, especially to begin with before surgery. And in terms of having a greater risk of overuse injuries like plantar fasciitis or shin splints or things like that, or more serious orthopedic issues, I stay far away from giving recommendations like this, especially for patients that are just beginning. However, if you have patients that are already exercising maybe have fewer comorbidities or maybe are younger, one good strategy in terms of exercise is the use of interval training. And this is something that I'll get to in a moment. We're doing a study with the University of Michigan looking at interval training in bariatric patients, but this has been done in athletes, it's been done in heart patients and cancer patients. And so kind of a standard interval training ratio that's used a lot is where you have 4 minutes of high intensity exercise up here at a higher heart rate, or you can also titrate the exercise based upon a rate and perceived exertion that we use for our bariatric patients, and we also use in cardiac rehab. And so patients, for this higher intensity would simply be down here and kind of the cusp of the hard where, you can handle it for a few minutes, but you can't do it for a sustained period. And then we have these recovery periods. And then as a person gets, more acclimated to the interval training, you can add 2 intervals, 3 intervals, 4 intervals to increase the time. And so for a given time frame, if we're controlling for time, a person's going to be able to burn more calories, and even more importantly, in terms of overall fitness, you get more of a fitness benefit if you are able to increase that intensity a little bit. But that being said, I'm very cautious, especially with new patients, trying to explain this because, again, there's a high risk for overuse injuries. And even just as importantly, we don't want to discourage them because could be very difficult to begin with. As far as I know, there haven't been a lot of studies in bariatric populations looking at high intensity interval training, but in overweight populations there have been, and this was a meta-analysis done a few years ago. And what they showed was if you control for the volume of exercise, so in terms of calories burned, there's really no difference in terms of moderate intensity continuous versus the interval training that I just showed you. And so what I always tell my patients too is if you want to do higher intensity stuff, that's great, but you don't have to. And so by no means should you be pushing patients to do high intensity. But that being said, as I mentioned earlier, the high intensity does have a benefit of having less time commitment. So that's kind of the balance you have to kind of think about as you're talking to your patients when it comes to exercise. As I said, we're doing a study with the University of Michigan and Dr. Brian Callahan, who's a neurologist there. He's done a lot of great research looking at distal symmetric polyneuropathy. And DSP, as some of you probably know, it affects a lot of individuals, especially those who have morbid obesity. And it's related to chronic pain, risk of falling, and lower quality of life. What we're trying to do in our study is we know that weight loss helps. We know that exercise helps. So really what we're trying to determine is there a synergetic effect with doing both, or does one help more than another? So we have 4 arms of the study. One arm is a non-surgery group who does the high intensity exercise or who does the routine counseling. And then the other group is a surgical group who does high intensity exercise or just the routine exercise counseling. And so the thing that really gets me excited and also kind of I have to pull my hair out a little bit with this study too is it's a 2-year study. So it's a long study, especially in the exercise world. Usually an average exercise study is about 8 weeks. And so, we're going to be able to report on a lot and learn a lot, and especially considering the fact that this study has been going on during the COVID pandemic. So when everything had to shut down, we had to shift this study to doing more online virtual exercise sessions. So we'll be able to look at the effects of that and maybe compare it to the in-person sessions to see, is one superior to the other? Are they equal? So we're going to learn a lot, hopefully, in terms of prescribing exercise to this population 2 years post-surgery. So as far as some key recommendations that I think is important for you to remember from this talk here today, the first thing is, as I mentioned before, there is strong evidence that exercise can help prevent excessive weight gain. And so every patient who is undergoing bariatric surgery needs to understand this and needs to understand if they're committed to this, this surgery, they also need to make sure they're committed to a consistent exercise program to help, as I said, protect that weight loss. Also, it's important to understand that, you can get benefits from exercise, whether it's moderate or vigorous. Moderate is typically more recommended for patients that are just started, but as a patient gets more acclimated, for sure you can do vigorous if that's something that they desire and it's appropriate for those patients. But again, you don't have to. It's really up to what the patient feels is going to work best for them. And really, when we look at the most widely used modality when it comes to exercise after bariatric surgery, 70% of patients, they go out for a walk, okay? And so that's definitely a message you want to continue to share with patients. And also a good point to share with patients is because even though we want them to build up to that 200 to 250 minutes a week of exercise, some is better than none. And in fact, when we look at the benefits in terms of mortality and really serious health issues, going from a complete couch potato to just a little bit of exercise has shown to have the biggest, bang for your buck. So it's always important to, encourage your patient, congratulating them, even if they're doing a little bit of exercise, but still try to help push them towards that stretch goal of 250 minutes a week. And then finally, important message is if you're telling your patients 30 minutes a day, that's not accurate, and that's not enough, not just to help them lose weight, and that's not even in this discussion, but 30 minutes, 5 days a week is not enough to help them prevent their weight regain. So studies have shown that you need more than that, and we'll talk about some strategies to kind of help with patients, because obviously that can be a barrier in terms of time. So speaking of which, I want to talk to you guys next about, what are some special considerations and then resistance training recommendations for patients, because there's more to exercise than just going out for a walk. And in fact, when we look at most patients who have bariatric surgery, a lot of patients are doing something in terms of going out for walks and things like that. Very, very few patients are doing any strength training. And strength training, while it's not going to show up on the scale, like I tell my patients, you step on that scale, it's not telling you how much fat you're losing, it's telling you how much weight you're losing, which could be a combination of fat and muscle. And the less exercise you do, the more likely you are to lose muscle. And what we don't know behind the scenes in terms of the body composition is what's going on in terms of the adipose fat, the visceral fat that we talked about. So that's something of a concern with our patients that become, in terms of regaining their weight. So this was a study done a few years ago by a group in 2017 here, and they looked at strength training, and they actually had 3 arms to this study. They had a general weight loss group that met in a class and gave recommendations about diet. They had an aerobic exercise group that wore pedometers and went out for a 45-minute walk each day. And then they had a resistance training group that came to YMCA and essentially did 3 sets of 10 to 12 repetitions on 8 different machines to give them a total body workout. As you guys can see here on the screen, is that there's quite a difference in terms not just the weight loss when you compare the no exercise to aerobic exercise to the weight training, but also don't forget about this part here. This is the lean mass lost, okay? And interestingly, in this study, aerobic exercise showed a little bit more lean mass lost. So really, again, you need to protect that muscle loss, and that's why resistance training is so important. So that's going to help you make sure that the majority of your weight loss is coming from fat and not muscle. And in fact, what that translates into, and we did a study a few years ago now, we looked at the amount of strength that patients lost after bariatric surgery. And I was actually astounded to see, the chest press went down and peak torque in terms of a leg extension went down. So this muscle loss is actually translating into functional capabilities being diminished. And that's certainly not a goal we want with bariatric surgery. And so it is very important that we are incorporating consistent strength training recommendations and guidelines in the patients. So as far as what these guidelines are, these are similar to what the guidelines are for healthy adults in terms of 2 to 3 days a week of non-consecutive days of weight training, 8 to 12 repetitions to close to volitional fatigue, meaning that by the time you get down to those last couple repetitions, you're tired. But one thing I do tell my patients is it really doesn't matter how heavy that weight is. So if you're not tired after 12 repetitions, go to 15, go to 20. I mean, if you're doing 50 repetitions, then you need to find a heavier weight. But for the most part, the most important thing is not how heavy the weight is, but how tired your muscles feel. And then as far as the time goes, add in additional sets that are spaced out. 2 to 3 minutes can be helpful. However, as you go from 1 set to 2 set to 3 set, even to more, you start to get diminishing returns. So really the sweet spot is around 2 to 3 sets for most patients. And the type of exercise should be dynamic. For the most part, although there are some isometric exercises like a modified plank that I've recommended in patients. Speaking about recommended exercises, if you're working with a bariatric patient, some exercises to consider, especially, since we are still kind of in the COVID crisis here, some things to do at home would be doing something like a modified push-up. Now, a lot of times when people think of a modified push-up, they think about, what this girl's doing here on her knees here, which can be very difficult for a lot of our patients. So, so instead, what we typically recommend, oops, the video doesn't seem to want to work today. Okay, that's all right. These guys are, there we go. Okay, instead is what we would recommend, like a wall push-up or some kind of modified push-up off of a surface, maybe a counter that a patient can use, because you're still using the same muscle groups in terms of your chest and shoulders and back of your arms and even your core. But now you're given something that's more doable for patients, that they can still challenge themselves, that they're less likely to hurt themselves or be discouraged with. Another type of modified exercise is, again, I love squats. I wish I could do the squats as well as this lady can do here. She's got great form, okay? I always point out to patients that knee is not going beyond the toes. But, for a lot of our patients, that's kind of tough. And so a good alternative is just simply a sit to stand. So this engages the same muscle groups, and you have that safety mechanism of having the chair behind you. And it also kind of forces you into good form. Another type of exercise that I've really warmed up to, I've been working with this patient population for nearly 20 years, and at first I was really kind of against resistance bands because I didn't feel like they had enough challenge to elicit any change. But there's a lot of different resistance bands that are out there. You can get with handles. You can buy a nice set at Amazon for $20 or $30. And there's so many exercises. As I like to tell my patients, you essentially have a gym if you have a good set of resistance bands. And so a lot of the exercises I especially like the back rows here. And often I'll do a combination of exercises where I might do a squat into a back row to save time and also to help teach good form, or a bicep curl into a shoulder press. So that's another way that you can actually help save time, and sometimes it can get you out of the monotonous of just doing one exercise at a time. So band exercises I really promote with our patients. Additional things to consider when it comes to your working with your patients. Number one is common sense, that hopefully you guys all know this, but I tell my patients, start low and go slow. And obviously we want to prevent overuse injuries like I mentioned before, but I think from a psychological standpoint, it's really important that these patients get some early wins, because for a lot of these patients, when it comes to exercise, they probably have had some unpleasant experiences, whether at the gym or trying it on their own. And so my first goal when I meet a patient is to make sure I can find something that makes them feel good and gives them a sense of accomplishment. But obviously you want to start to challenge the person, and so having a plan of progression is also important with that. The other thing is, as I mentioned before, sometimes it can be challenging to get patients to do 200 to 250 minutes a week of exercise. So an essential strategy for that is to break up the exercise bouts. And, when you put it in this term, so you tell the patients on your lunch break, take the stairs or go out for a walk, or, do a short walk with your dog for 15 minutes in the morning, if you can make it more manageable in terms of that, then, long-term success can be better for those patients. The other thing I would have you consider is make sure you talk to patients about some non-weight bearing exercises. So again, when you get a patient in front of you and they're excited about bariatric surgery, they'll do whatever it takes to do that. So that's one of the reasons why I love working with this population, is because they want to do the exercise because they want to get the surgery. But you have to sometimes be careful with that enthusiasm, because again, this leads to a lot of overuse injuries. So if a patient starts walking an hour a day and their body's not used to that, that's the biggest reason why we see those overuse injuries. So it's always good to have some backups. And one really great option is to, show them some exercises like chair aerobics. Now, I'm sure a lot of you guys are familiar with chair aerobics, probably recommend to your patients, but have you ever recommended chair aerobics using paper plates? So this is a video that I have on henryford.com. You guys are welcome to send your patients there and just have them type in chair aerobics under the search, and they can find this video. But essentially, when you have the paper plates, you open up a new plane of motion that can allow patients to do more movement to keep their heart rate and breathing elevated. So that's an option that you can have as well. Another strong recommendation that I have for all our patients is to start to track their activity. Now, it seems like more and more patients are starting to do this, but it is very important, because studies have shown that patients who track their steps burn more calories throughout the day, and the reason why is because they're more aware of. Now, unfortunately, just like with The Biggest Loser, there's a lot of misconceptions in terms of how many steps a person should have, and often I'll hear that bariatric patients are told by somebody that they need to do 10,000 steps a day. And that's a great goal to eventually work up to. But we did a survey of patients between 2019 and 2021, and we found that the average step count for these patients was under 5,000 steps a day. So if you're telling these patients to get up to 10,000 steps a day, that's a pretty tough goal, especially to begin with. And so there's a recent study that has looked at activity trackers or steps, and found that when it comes to the best improvement in terms of lean body mass and loss of abdominal fat after bariatric surgery, what they found was the patients who were able to at least increase their their pedometer steps by 3,000 steps a day had the best outcomes. And so my goal for patients is I don't give them some arbitrary number like 10,000 steps a day, because really I'm still trying to figure out where that number came from. However, if we set a goal of 3,000 steps more than what you're doing, then that's a more manageable goal. And in fact, when we look at the public health guidelines of that 30 minutes, 5 days a week, really that equates to around 7,000 steps a day. So I really emphasize to the patients, you got to, wherever you're starting, that's fine, and start to build upon that and try to get 3,000 steps more. So at this time, I'm going to get to the last part of my talk, and I'm going to talk about the importance of not just talking to patients about exercise, which obviously I think is very important, but actually letting them experience exercise, because I think that adds a whole new realm to what you can do with your patients and how they perceive and understand what you're trying to get across to them. And so I've been doing a bariatric class here for nearly 20 years, and it's had various iterations, but for the majority of that time frame, the basis of that class has basically been either myself or one of our other exercise physiologists to be working with the patients on the exercise floor, get them on the machines, get them on the treadmills, have them do some weight training, and let them see and feel what they should be doing. And I could tell you that, I've experienced this where a lot of patients are very resistant to kind of sharing any information with you at first, but you get them on a machine. I remember I had a Ford executive who just didn't want anything to do with his appointment with me. But as soon as I got him on the treadmill and he started walking, and it was really the first time he reported exercising since he was in college, his whole demeanor changed. And I think that has a great, benefit to the patient to show them, yeah, you can do this. So I think that's really important. Just as important is to, kind of show them how they should feel during exercise, give them the evidence-based exercise prescription, as I've shared with you guys, which hopefully will improve their long-term adherence. But the other thing is when you have a patient who's on a machine, now you can see what they're actually doing, because as we all know, when it comes to exercise, patients exaggerate how much exercise they say they're actually doing. Actually, studies have shown that if a patient says they're doing X amount of exercise, chances are they're doing at least half of that, okay? So if a patient tells me, oh yeah, I walk 30 to 60 minutes 3 days a week, then I usually write down, okay, walks 30 minutes, 3 days a week. So it's commonly done, okay? But, having a patient on a treadmill or on a bike can allow you to see what they're able to do, or if they're having any problems. So if I have a patient who is on a treadmill, is really huffing or puffing, and they're at high risk of cardiovascular disease, then this gives me, a way to communicate with the surgical team that this is a patient that we may need to watch a little bit closer to make sure that they're going to be able to get through and not have any issues with the surgery. And in fact, we know that functional capacity, a person's ability to exercise, is one of the single best predictors of mortality and morbidity and complications with surgery. So there have been many studies to look at this, and this graph here, this is a classic study by Myers that was published in the New England Journal of Medicine, showed that regardless of the risk factor, if you have COPD or if you smoke or if you have high cholesterol, what determines the risk of death the best is how fit you are. So the more fit you are, okay, at 8 METs or more, then you're less likely to die sooner, okay, even if you do have hypertension, even if you are diabetic. And there was a study that was done back in 2006 that did some peak stress tests on patients, and found that those who had a MET value less than 5, they were at greater risk for complications with surgery. Now, typically we don't put all our patients on stress tests when they come in to see us. In fact, very few we do. But, and I guess I forgot to mention, studies have shown that if you're able to improve your METs value in terms of your functional capacity, it results in a subsequent decrease of death and cardiovascular events by 13 and 15%. So fitness is good, and improving that fitness can reduce complications. And so, as I was saying, even though we don't necessarily do stress tests on patients, because we see them beforehand, get them on machines, we at least can see what they're doing from a submaximal exercise perspective, or what they typically would do with training. And so what we wanted to do was kind of look to see what kind of self-selected workload they picked, and based upon the RPE scale that I shared with you earlier. And can that predict complications with bariatric surgery? And so this was a retrospective analysis we did of patients from 2015 to 2018. And we looked at various complications, both during surgery and post-surgery, to see if the exercise the patients did with us before had any predictive value. And right off the bat, and I wasn't surprised with this at all, when you look at patients who are unable to get on a treadmill and walk, okay, so these are limited patients, typically they're going to be older, have knee problems, orthopedic issues. Those patients that had to do the seated new step, they had a much greater percentage of complications across all the different complications we looked at. So again, if you have a patient who can't walk, that should be a red flag, in terms of you definitely need to keep a close eye on that patient, to say the least. But when we just looked at treadmill speeds and converted that into MET values, we found that there is significant values just looking at that. Now, of course, we adjusted that for things that you might expect, like age and sex and BMI and smoking history. And even though a lot of these p-values, or this p-value didn't remain, we did still see a significant difference in terms of 30-day emergency department visits. So again, the more fit you were, the more exercise you were able to do on the treadmill, the less likely you were to go back to the ED 30 days after your bariatric surgery. So hopefully what we'd like to see is, again, taking these higher risk patients, and can we help maybe get them on a more rigid training protocol to help maybe even lower that. So I really appreciate everybody's time here today. And in fact, I hope this was helpful in terms of some information that you guys might be able to share with your patients. Hopefully you won't have to just rely on Google anymore. As a dad, I know that I've become a secondary source to my kids when it comes to Google. They'll normally ask me for about something, and then if they don't believe me, which is most of the time, they'll just go and ask Google or Siri or whatever. But I just want to point out to you guys that Google is not always right. So I did a search for exercise and weight loss, and this was the top hit that I got. A new study shows that 30 minutes of exercise a day works just as well as an hour of exercise helping adults lose weight. And hopefully after my talk, you guys understand that that's completely false. And so really my comment in terms of this study, first of all, a new study that came out in 2012, I'm not sure how that's the case, but really here's my response to that. So anyway, I really appreciate everybody being on the call today. I'm happy to answer some questions, and again, thank you for everybody's time.
Thank you, Dr. Kerrigan. It looks like thus far we don't have any questions in the chat. So you answered everyone's questions about exercise.
I guess I did. Wow. Okay.
I guess. I have a couple of questions, but I think you said you also had some slides you could share on COVID. So I didn't know, do you want to talk about that? And then we can see if that maybe drums up some more questions, or do you want me to ask a couple questions first? Okay, well, maybe while people are kind of thinking about questions, I can pull up my slides on COVID. I wasn't sure if I would have enough time, but yeah, I'll go back and I'll share my screen and I'll bring up those COVID slides. Great.
While you're doing that, we do have one question from Melissa Dusselgy. So Melissa, if you'd like to go ahead and ask your question to Dr. Kerrigan now.
Sure. My name is Melissa. I'm a PA at the Bariatric Center in Kalamazoo. We currently do a group fitness class as a pre-op requirement, kind of just overall going over kind of some of the things that you mentioned, recommendations, pre-op, post-op. But do you recommend more individual assessments for patients on a one-on-one basis?
Okay, I think I caught that. Your question was about individual assessments for patients?
Yeah.
Okay, so with the group class, it's a small group class that we lead. And so we typically have a ratio of one exercise physiologist to 3 patients. And so with that, you know, we're pretty much able to connect with the patients in terms of talking to them, seeing what they're able to do, you know, check their heart rate response. If a patient is deemed higher risk, or if they need, you know, further assessments, or just further follow-up, we certainly we have them come back and we see them one-on-one. For the most part, I don't know if it's, you know, it'd be nice to see every patient, you know, one-to-one. There's just so many patients and so few of us really. But I do think that the small group is definitely better than, at one time we would have like 24 patients to 2 exercise physiologists, and that was just way too much of an imbalance in terms of that ratio. But I do feel like we're at least able to connect with the patient with that 3-to-1 ratio, and then also, flag those patients that might be having problems or need some extra assistance.
Thank you.
Thank you. Okay. Well, Kelly, should I go ahead and share my questions? And then if anyone else has any other questions, they can put it up on the chat.
It
We
does
have
look-
one.
Yep,
We have
go
one
ahead.
other question from Sharon Bibbs, and her comment was, "Thank you, great presentation." And then I've allowed Sharon to ask her question. So if you want to go ahead and ask your question now.
Good morning. Can you guys hear me?
Yeah, we can.
Okay. It's Sharon, actually. But I was wondering, I know you said that the patients can look up chair exercises on the henryford.com website, but I seem to get a lot of questions on, like, what they should do for exercises. So do you have any other links on Henry Ford or sites that I can give them to help them with exercise?
So I could say with that same website that has the chair exercises, I do have some additional strength training exercises with the bands. So that could be a good resource. The problem, when it comes to just giving generic like websites or whatever, is because there's such a variation between really high functioning bariatric patients and very low functioning bariatric patients. So really that's why I think it's important to do that initial assessment to kind of see where they are before you necessarily direct them one place to another. But like I said, the exercise that I have on the Henry Ford website, probably geared to more like the lower functional patients, but these are exercises that some things out there are just crazy and can be unsafe,
Right.
and so you won't find any of those on our website.
Okay. All right. Thank you.
All right, thank you. Okay. Any other questions, or should I go on and talk about COVID? Okay.
It looks like we have just a couple more. So questions. Just working to find them.
No worries.
Dr. Wood, if you'd like to go ahead and answer your question. All right, I'll go ahead and ask Dr. Wood's question for him. So he wants to know, do patients pay cash for the training, or does insurance cover it?
Oh, for the exercise consult, it's covered by our HAP insurance, so that part of it is covered. We do have an exercise program that patients can attend afterwards, and so that is cash pay. That's $50 a month for that. But with the initial assessment, if they don't have HAP, then that assessment is $57, and then they can come back for a free assessment or follow up if they want.
One other question from Melissa Dusselgy. She wants to know if you recommend, are there any apps that you can recommend that patients can use?
Oh, that's a great question, Melissa. Yeah, so really, as far as the apps that I recommend for patients, the one that pops in my head that I recommend a lot is Map My Walk. Or Runkeeper. Those are essentially the same. They're glorified GPS devices. So since so many of our patients do walk for their exercise, I think it's important to track their progression. And so those two apps I really like for our patients to use. And again, I don't know how many of you out there use the Bariatric app, but we also emphasize that our patients track their exercise in the Bariatric app. along with their food.
And then we received one additional comment in the chat from Wendy Whitfield. Wendy, if you'd like to go ahead and sort of make your comment and ask your question now.
Sure. Yeah, I recently had a patient who previously had not exercised before surgery and then started a vigorous exercise program at 3 weeks post-op and had a weight loss stall for those 3 weeks until she stopped that vigorous exercise. She was only getting about 400 calories a day. Do you see some, I think she was stressing her body a little bit. Do you see this often, prohibitive weight loss with vigorous exercise too soon?
So that's interesting. Yeah, really, when you look at the effect of exercise after bariatric surgery, because I did a study a long time ago looking at this, and the impact of exercise on weight loss seems to be very minimal during the rapid weight loss after surgery. That's interesting about your comments about having kind of a stagnation in weight over 3 weeks. Of course, I mean, 3 weeks period, that's, you know, it's a small sample size, if you will. But I think in general, you know, when it comes to post-surgery, we're really cautious, especially in terms of weight training activities, to kind of keep those light or really not to focus on those until at least 4 weeks after surgery, unless the surgeon is completely comfortable with that patient. And the other thing when it comes to exercise is to, again, kind of gradually increase that. So I stay away from vigorous exercise in general for more orthopedic and adherence issues. I can't say that I've run into a lot of issues in terms of stagnation of weight loss, but that's an interesting case, Melissa.
Thank you.
All right, looks like the questions are starting to come in now. So we have another question from Kelly Liggett. If you'd like to go ahead and ask your question now. All right, I'll ask Kelly's question for her. So her sort of question comment is that she sees patients individually with limited resources like no gym access. Are there any assessment tests that you can recommend that can be performed in an office setting, like push-up tests, 6-minute walk tests, those types of things?
Yeah, that's a great point. 6-minute walk test could be utilized in some of our patients, probably our lower functioning patients, our patients that are, you know, in their 20s or 30s and have very low comorbidities. There's kind of a ceiling to that test. Another test that I use in our cancer program that I think could translate nicely would be the exercise I showed you, the sit to stand. So how many sit to stands can somebody do in 30 seconds? So that's something that's a repeatable test that you can do in the office. So I would maybe consider something along those lines.
All right, we have another question in the chat from Dr. Miller. If you'd like to go ahead and ask your question.
Sure. Thank you for the great talk. My question is just regarding the program. On average, how many consults does the bariatric patient have with the exercise physiologist in your program, like during the pre-op phase and the post-op?
Sure. Great question. So everybody needs to see us at least once. So to answer your question, at least one time. As far as the follow-ups, as I said, you know, we may flag some patients that may be coming in a wheelchair or, you know, are high cardiovascular risk that we may see again. And then, of course, we offer patients a follow-up and our exercise class, which a percentage of patients do that, but you know, because of work schedules or where they're driving from to get surgery, we don't capture a lot of those patients. But it's at least a one-time, you know, connection with those patients. And we do have a Facebook a group that patients, you know, do sign up for, and they can see exercises online and stay connected that way as well.
All right, looks like we just received another question from Tara Farley. If you'd like to go ahead and ask your question now.
Hi, Dennis. Can you hear me?
I can hear you, Tara.
Okay, I was just wondering, I mean, do you guys do body fat analysis at any point during the process, especially post-op, to kind of assess their progress rather than using BMI or rate of weight loss?
We do have a bod pod, and so we do body composition analysis on patients that want it. It's not a requirement. Along with that, we do take a waist circumference, which, as I tell my patients, that's really the best predictor of chronic health conditions. But I mean, in some patients, we've had serial testing from before they had their surgery to a couple years after their surgery. So it's been very helpful in some select patients. I always enjoy seeing those numbers. When I have a patient that hits a standstill, sometimes they'll come back and see us to do a body composition. I think sometimes it can be reassuring to some patients, especially if they're doing a lot of exercise, because there are some patients I believe that a lot of our bariatric patients, they're genetically have a disadvantage in terms of being able to gain weight, but a lot of these patients can easily gain muscle more than other individuals as well. And so, being able to show them that, even though your weight's been about the same, we are seeing a greater improvement in your body composition. I think that that's helpful for patients, but by no means do we require a demand for all patients to do that.
All right, so it looks like we've answered all of the questions in the Q&A and chat. So Dr. Kerrigan, if you wanted to cover a few of your COVID slides now.
Okay, sure, I'd be happy to. So I only have 3 slides here. I wasn't sure if I would have time to go through these, which I cut these out, but since we have some time here, just what I'm sure everybody wants to hear is more stuff about COVID. But as you guys are well aware of, when it comes to the complications with COVID, obese individuals are at high risk. And this is probably the reason why it seems that bariatrics and weight management seems to be busier than I can remember in a couple years. With patients who are overweight with a 113% higher risk of hospitalization and 48% higher risk of death than somebody of normal weight. And part of the kind of biological plausibility under why that happens, it has to do with probably the metabolic disease and the inflammation that occurs that seems to get spiked in the cytokine storm that happens with COVID. We did a study, and similar to what I shared with you earlier about other studies looking at mortality and fitness, we looked at fitness from patients who just before the COVID struck in early 2000 had a stress test with us at Henry Ford, and we stratified them from low fitness to high fitness. And we looked to see, what their risk was of being hospitalized with COVID. And first of all, the good news is for all you females out there, women had a much lower incidence of hospitalizations than men did. However, regardless if you're a woman or a man, your risk of being hospitalized was directly correlated to your fitness level. And so this is something that often gets overlooked in terms of these studies that show high-risk patients. Most of these studies don't have the ability to look at a person's fitness, but this study here we did show that. Now, I actually did another analysis in a subsequent follow-up paper to look at the risks of COVID associated with all the different risk factors you can see here on the left. And we did a univariate analysis, and then we adjusted it for fitness, okay? And after we adjusted for fitness, you see that all these risk factors that were significant in terms of hospitalization with diabetes and heart disease and cancer, they went away once you adjusted for meds. The only thing that didn't go away was kidney disease. Now, interestingly enough, with obesity, we didn't find a relationship with obesity and hospitalization in the cohort that we looked at. And partly why we probably saw that was because these were patients who did a stress test on a treadmill. So if you were too obese or you had orthopedic issues, you'd probably get a non-invasive stress test or a non-exercise stress test. But interestingly enough, these patients, when you adjusted for meds, there almost was a paradoxical effect in terms of obesity in these individuals that were at least fit. And that actually has been looked at before, looking at, can you be fit and fat? And studies have shown that, again, even if you're obese and you exercise, the exercise can help protect against a lot of the chronic health conditions. Even though we're still promoting weight loss, it's just another, hopefully, confirmation for your patients that might not be at their ideal weight that they like to be at, when they were in college, but are doing all the right things. So hopefully that can be helpful for you guys. So that's all for my presentation. So again, I'd like to thank the Henry Ford team, thank Dr. Martins and Dr. Hammond for inviting me to this group, but I'm very excited to be here. And it was great to talk to some of you and answer your questions. You guys feel free to reach out to me if you do have more questions about any of your patients, or would like to just talk about exercise, because again, I can do that all day long. So thank you again for all your time, and I'll hand this back over to Amanda and Kelly and Aaron.
Well, thank you so much, Dr. Kerrigan, for an excellent presentation. Thank you all for attending, and hopefully it was informative. Certainly thank you, Rachel and Amanda, for facilitating. Just want to make sure that everyone marks their calendar for the next triennial meeting. Hopefully we'll see you all there. And we will keep you updated on the plan regarding the integrated health meeting. As Dr. Kerrigan mentioned, don't hesitate to reach out if you have any questions, and certainly you can reach out more specifically to Dr. Martins or myself. But hopefully you have a wonderful day, wonderful weekend. Dr. Kerrigan, that was excellent. Thank you so much.
Thank you, sir.
Thank you. Bye, everybody. Take care.